Hi, my name is Jack Crow. I am an aortic dissection survivor, and I am an aortic athlete. And we're doing something a little different today. You can tell from our background. Usually, my colleague Carmen David, who co-founded Aortic Athletes, is with me to do these interviews. Just so happens I'm at Cleveland Clinic having my regular scan. And we thought we'd take the opportunity to do a live interview here with the director of the Cardio Rehab Clinic, Dr. Van Iterson. But before we get to him, we have a little bit of business to do. First, see that little button down below? Click like, and so that artificial intelligence sends this video to others in the aortic community. And also, if you're not a member of Aortic Athletes, go to Facebook. We have over 1,000 members from around the world, and we have all manner of aortic disease. And come and join us and participate, get support, and more importantly, you'll follow the science of how to exercise safely with aortic disease. Which reminds me, we always want to say at the beginning that you need to check with your cardiologist about you and about your exercise routine. We have aortic athletes who have dilations, who are in watch and wait with aneurysms, who've dissected like me, or who've had aneurysm repair and are doing great things. But because we're each in a different place, each in a different stage, some have syndromes like Marfan, you need to check with your own cardiologist first. So with that caveat, let me introduce Dr. Eric Van Iterson from the Cleveland Clinic. And Dr. Iterson, welcome.
Thank you very much, Jack, for inviting me to your lovely show. I appreciate you sticking around. I know that traveling for care can be tiring, and you've taken your afternoon to talk to me and me to talk to your audience.
Well, I wanted to start just by learning a little bit about you. I'm a Chicago guy, and I saw on your resume you were at DePaul University and University of Illinois. Tell us a little bit about how do you end up in a place like this?
Well, in the best interest of time, I'll give you a Cliff Notes version, and that all sort of started out when I was a youth and loved playing sports and was interested in athletics and also interested in, believe it or not, the heart and the body and why our body enabled us to do those things. And it all cascaded from there in terms of guided my education choices and then guided my professional choices in being able to not just help athletes, but also help patients of various backgrounds and conditions and enable them to have the best information possible so that we can all enjoy benefits of exercise, no matter who you are and no matter what your condition is and your situation is.
Well, we're calling this interview today the journey of cardio rehab after aortic surgery, whether it's ascending or descending, whether it's open heart or EVAR or TVAR. But what is it that we can do before surgery? If we're coming up to major open heart surgery or other procedures, is there anything we can do to improve the likely outcome?
Well, I think in general is that exercise is universally good for all humans, and that as long as the exercise that you do leading up to your surgery is appropriate, specific for you, then it can't hurt in terms of that recovery process, which in addition to the obvious surgical procedure, there's also going to be a great deal of effect from having to lie in bed for a good number of days because of the invasiveness of your procedure. And that can't be dismissed in terms of the influence of bed rest deconditioning and how that affects your physiology, biochemistry, your fluid balance, and those things all going to greatly affect how you perceive exercise, how you perform exercise. And you don't want those types of feelings to discourage you from when you start exercise again. And you don't want those things to surprise you either. And so doing some of that researchable conditioning can definitely be beneficial. But it's important not to take a brute force approach and really try to accelerate and overload yourself to extreme levels and trying to extract those benefits in a very short period of time.
Well, we're going to talk as we go on a little bit about how you know what is light exercise, what is moderate exercise, what is vigorous. But before that, I've heard that you can lose 20% of your muscle mass after open heart surgery. So if someone is at the Cleveland Clinic here and in the couple of days after open heart surgery, what can they expect? Can they move at all? Can they get out of bed? Should they get out of bed?
Yeah, no, great question. And yes, absolutely. Is that when you're inpatient, we want individuals to get up and walk around, ambulate, like we call it. And we want you to be able to sit up in bed, and not just because we want you to not be bored, but because it's actually very physically stimulating for skeletal muscle in your body and to offset that deconditioning effect and the role it's going to play in not just the loss of muscle itself and the strength, but fundamentally all of that aerobic machinery that you use and that you rely on to do actual exercise. And that when we talk about strength, is that should encompass that cell makeup that lies deep within that tissue that you're losing, in addition to the strength as well. So yes, absolutely, you should get up, walk around, as long as inpatient staff are comfortable with you doing that.
And then when I went home after dissecting, I dissected at a rural hospital in central Wisconsin that happened to have a great thoracic surgeon who saved my life. And he told me, when you go home, he said, I want you to walk even around the house 5 times a day for 5 minutes. And he said add 1 minute to each one a day. And in my crazy way of thinking, as an old Ironman triathlete, I thought, aha, now I have a target. And I was walking a mile, 2 or 3 or 4 or 5 eventually, within a month or so. So how should people approach that, when they get home?
Yeah, well, I think that recommendation of the 5 times a day for 5 minutes initially to begin with is very much appropriate in terms of it. It's purposely breaking up the sedentary time that you might normally want to just sit and rest because you're actually tired from, again, recovering from the procedure, but tired from actually itself being in bed for that amount of time. But of course, with an athlete, the danger becomes of you set a target and your natural goal is to, well, I'm not going to just meet the target, but I'm going to super exceed the target. And that's where you don't want to unintentionally do something that you, of course, were never setting out to do. And the fast pace of training progression can really lead you to some unwanted feelings generally in the body that won't necessarily reflect the success of the surgery, but certainly can make you feel uncomfortable with not just during your sessions, but after your sessions. And it may take you extra time to recover, and that might be something that you're not used to, and you're starting to question, is something wrong? And again, those are negative experiences with exercise that you shouldn't have to experience because you're trying to do something very positive first.
We have aortic athletes who work on the farm, who are carpenters, who are, working in a manual labor setting, and they want to go back to work 2 or 3 weeks later. How would you counsel them?
Well, I would say it's commendable that they're that motivated and that they work such a physically intensive profession. But I would say, as big picture, there is no immediate rush for these types of things, and that we want you to be able to exercise for the rest of your life, not just for the next few weeks. And we want you to be able to do aspects of your job forever, for as long as you choose. And that by starting them before you should, or trying to accelerate them at your own predetermined pace, that isn't going to make it better or safer or more effective. It's, again, more likely going to cause you problems down the road of possible complications with the procedure, or again, just general discomfort and unease and concern and worry. And oftentimes those feelings lead to the choice of not doing anything at all eventually. And that's not a situation we want any individual to be in, because when then you decide to go do something, your body is going to be very surprised as to what you're making it do. And it's going to give you all these hallmark fight or flight responses, because it's literally scared of what you're trying to make it do, because you haven't been doing it regularly.
That's why our aortic athletes motto is don't quit, adapt. And my personal motto is little by little by little. Nothing in so how soon after surgery should people think about starting cardio rehab?
To be honest, for many individuals, it's within 2.5, 3 weeks. And that would even include, as part of our initial assessment, doing a full out maximal incremental exercise test, so that in our controlled setting, we have you monitored, we have the protocol in place, we have all the procedures in place, but we can also evaluate not just the safety of exercise, but your cardiovascular response to those graded stages of work, as well as evaluate what's your perception of that work. And that's important, because oftentimes as athletes, everything is easy until it isn't. Okay. And physiology doesn't work that way, that you don't go from easy to impossible, but you do go through a graded phase. And that's important as part of that education as well, to allow individuals to understand that it is okay to work along the spectrum, and it doesn't have to be at the polar ends of that scale.
So as I'm listening to you, it sounds like I'm hearing two themes. One is the physical theme, the physical recovery. The other is very much, sounds like the psychological. Absolutely. And we did a survey of aortic athletes, and one of the ahas that came back was that 3 out of 4 aortic athletes experience fear of exercise. So how does cardio rehab play into helping that?
I think tremendously is that I honestly believe the initial part of cardiac rehab and exercise training after leaving the hospital and being cleared to start this journey is not the physical, but it's actually the mental, the comfort of regaining the confidence. And you can do intentional structured movement that isn't just activities of daily living. Yes, it may not also represent your old training regimen, but that it is an elevated metabolic load on the body, and you are technically doing exercise, even though it may not be something you would have normally chosen to do before all this. And to be able to not just do it one time, but to repetitively do it, which engenders a great deal of confidence in the individual to be able to feel fine in the midst of the exercise, when they get done with the exercise, and when they go home. And then have that confidence that I can come back and do this again, and I'm not worried. And that really is a very additive process over time, which is partly by design of cardiac rehab. And it's not just one session, but 36 sessions. And you get that dose concentrated exposure to exercise in a very controlled setting. And so, yes, eventually the physical aspects of things start to fed in, but for a good amount of time, I truly believe most of it is the mental comfort, awareness, and the ease of concern that you're doing harm.
So when people are on a treadmill, maybe with some electrodes hooked up, and they're fast walking, and you're giving them the thumbs up based on what, the blood pressure, or what are you looking at?
Yeah, so that comes back partly to the exercise stress test, and we're getting real heart rate measurements throughout that entire test. And so I can then look at all that data and calculate actual representative intensity levels for you and you alone because of what you performed at. And so then, as part of the exercise guidance, I'll document as part of your cardiac rehab plan, I'll actually specify a target heart rate zone that I think is effective, safe, and appropriate given your present circumstances. So then when you are on telemetry in cardiac rehab, we can see objectively how hard metabolically are you working. And that being objective, which is important, because again, can't just rely on asking you, how do you feel? Because again, there is typically going to be that tendency to grade it as easy or mild until you continue to work your way up, when then you're breathing fast and hard, and all of a sudden you have to stop. And well, it's both, because of the fact that, well, unfortunately, can't monitor exercise blood pressure in a real pragmatic way outside of the cardiac rehab center, and you can't do it at home. And so when we do that exercise stress test, we get heart rate and measurements of blood pressure. And so then you can see at what heart rate is the blood pressure at what level. So you're using heart rate as the most pragmatic, objective cardiovascular metric to guide you in terms of what, if you could take your blood pressure, would your blood pressure be at that level? And so that's important in terms of your real world of, you're not in a lab at home and you don't have someone taking your blood pressure at home. And so giving you sort of an exercise blood pressure guide for you to follow, it's not something you could actually follow. So the next best thing is your heart rate and the equivalent of it for your blood pressure.
I think our aortic athletes, I put us in like 25% of people with aortic disease are kind of intentionally exercising, probably more than the average American. And it runs the gamut from people who are walking every day to people who, we have one guy, shout out to Michael Abresti, who had a repair two or 3 years ago and just did a 130-mile ultra run in New Hampshire. So that's impressive. And all, by the way, pretty low heart rate. Mm-hmm. He did that kind of little by little leading up to it. But should the exercise stress test be taken out of the cardio rehab clinic and into the offices of cardiologists? Should this be kind of a normal thing that, let's say you're in watch and wait, that you're asking your cardiologist if you can do because you do want to exercise a little more?
Yeah, absolutely. I firmly endorse that, and that even if it's, say, prior to a procedure or you're being medically managed and can't technically do cardiac rehab, is absolutely ask your cardiologist or PCP if you can do exercise stress tests so that you can acquire that information, which is a very valuable resource, because then you're making decisions based on information and data, and it isn't so much a try it and see approach. And I think you can truly be the most responsible about these choices about exercise, because then again, you have some real objective metrics to know when someone says exercise at moderate intensity, then you have an equivalent of what exactly is a moderate intensity equivalent of a heart rate range. And so in that way, you're in control of your choices and you're also accountable for them too. And you can also then ensure yourself, for the most part, a very predictable response from your training session. No one wants surprises, but that can easily happen when you're just kind of going about, how do I feel with this session? Because honestly, most adults, how they feel changes by the hour. And so that's going to be a very wavy and dynamic sort of scale, even though moderate is moderate. Well, moderate at 8 a.m. from a physiological perspective is going to be something different at 2 p.m.
And it's something different for those of us who are on beta blockers.
Absolutely. Absolutely.
What do beta blockers do to ruin my run this morning?
Well, hopefully you change your mind about ruin part, but that can think of, well, the intent of that medication is to help suppress your heart rate, help control that blood pressure rise with intentional exercise or exertional stress, but that it shouldn't be viewed as something that is preventing you from being successful with your aerobic exercise, because I absolutely think you can be very successful with your aerobic exercise, even with those medications, and have the protective effects of those. So the key is to understand these chemicals, they do have a temporality to them in terms of how strong of an impact they're going to have on your body when you take them and when you exercise. And I always counsel patients as to a good rule of thumb is don't change your medication regimen around your exercise, but make your exercise consistent on a session to session basis of what time of day you're doing this relative to when you're taking your medications. So then you get a relatively consistent effect of that medication on your heart rate and your blood pressure. So it isn't so out of control as you might think day to day, because if you're taking your medication at 8 a.m. and then you exercise at 9 a.m., you're going to have a pretty potent effect of that medication on suppressing your heart rate and blood pressure, which is a good thing. But then the next day, if you decide, you know what, I'm busy in the morning, I can't exercise at 9 a.m., and you have to exercise at 5 p.m. before your second dose, and that by 5 p.m., that medication isn't going to be working as strong on your heart rate or blood pressure. And so at that time, maybe you hardly do anything before your heart rate's already in or above your target heart rate zone. And you feel like, what's going on? Why is my heart rate out of control today? And I really can't do anything because I'm out of my range. And that can be a very frustrating thing. And so it comes back to information knowledge of why is it doing this, and can I control it by making a different choice?
So it's exercising safely is preeminent. That's number one. And I had to give up being an adrenaline junkie after my dissection. Those days were gone, and I have to content myself. A year ago, I ran the New York Marathon, and my average heart rate was 117 for 6 hours, and my blood pressure was always below 120/80. So I think that what I hear you saying is, it's disappointing, but it's for a good purpose.
Well, it also should be viewed as your heart rate scales in terms of if you're doing a stress test, you're still going to have a maximal heart rate. It's not going to be what it was before your medications. But if it was truly max out physiological effort, it's still going to be your relative maximal heart rate. And so anything calculated below that should still be relatively equivalent to the same intensity as your unmedicated heart rate would have been. Yeah. And so I don't want you to feel like you're sacrificing performance in an absolute way. You just have to think about it differently in terms of what's the intent of the therapy. And again, that goes to the importance of getting that information of what is my body responding to at these different levels of stress. So then you know, again, how much demand you're putting on your blood flow.
So can you help us with a definition of what moderate exercise is in general, like from a cardiovascular point of view?
Yeah, I would say in terms of, it's right below that sort of fundamental lactate threshold. In terms of, you don't want to quite get to that level where you're triggering the breathing to need to start to increase in speed and lessen in depth, where you're trying to blow off that acid in the muscle that's accumulating from metabolic byproducts. And that if you're at that point, you're no longer really in the moderate domain anymore, but that there's a reason why you're breathing more. And that's because your body's simply trying to re-regulate itself from an acid-base standpoint and to try to prolong the exercise and prevent that bonk effect where metabolically you can't clear out that acid fast enough.
I used to bonk quite a bit.
So you did an Ironman.
Yeah, I do. I used to bonk all the time. That was a regular thing, and I don't anymore. And I'm much more careful about my hydration and my heart rate. And so, is it heart rate? Can heart rate tell us whether we're exercising moderately or not?
Yeah, absolutely. And again, is that that's where making sure though you have real information that's representative of you right now in your present state to ensure that the calculated heart rate level is indeed what you intend it to be in that, say, moderate to somewhat hard domain, and not off of these age max predicted equations or other sort of color charts or zones, because those don't take into account your medications. Those don't take into account your fitness level of, you've been out of the hospital for obviously quite some time, but other individuals who are just getting out of the hospital and it's a month out, is that you don't know how to really account for that conditioning effect that you lost while in the hospital either, no matter how fit you were going into that procedure.
All right, you've taken us back to cardio rehab post-surgery. And all right, so here's what some aortic athletes who are hard chargers will say. Cardio rehab is for old people. So how do we address that?
Well, I would say everyone is entitled to their opinion, all right? And that I'll also admit that I don't know every single thing there is to know about exercise either. And that I'm always trying to learn new things about exercise. However, what I do for a profession is what I do for a passion and interest and trying to acquire that information so I can help everyone. And so if I'm still trying to learn about this topic of exercise and heart health for all individuals, then I do think everyone should be open to giving cardiac rehab a try, and that it can't hurt you, if anything. And I think it can only benefit you because it is all about information gathering so that you can ultimately make the decision for yourself in a real world basis, day to day. You're not going to be in a cardiac rehab center forever. It's only a fixed amount of time, but that on a day-to-day basis where that's your life, you do want to be able to make a decision based on information that's in your best interest.
Well, it takes a little bit of humility. I always say that after I dissected, it was like being run over by a tank. And, little by little learning how to get back to exercise was helpful, and cardio rehab was helpful in that sense. What about availability of cardio rehab? Because we have aortic athletes whose insurance denies them cardio rehab. If they had had a bypass, it would be covered because that's related to cardio and the heart. But because it's an aorta, the exact same open heart procedure of cracking open the chest and everything, they don't get it.
It's frustrating. It's, that is quintessential bureaucracy with insurance, and that is unfortunate that lawmakers can't see this as being a fundamentally important thing for individuals after open heart surgery for aortic admission. That in the absence of having insurance coverage for cardiac rehab, I would still recommend, for example, if you are in the greater Cleveland area or willing to travel to Cleveland Clinic, is come in and see me, and we can do an exercise prescription visit where you'll have to do a stress test. They'll have the same type of conversation I would with you about the importance of appropriate aerobic based exercise and document a full out exercise training plan for you as if I would do if you're here doing cardiac rehab, so that you can self-monitor yourself at your house, at your local gym, and you can make those choices because you have that conversation with me in terms of why you're making those choices. And I think that is important of not just telling someone to do something a certain way, because by nature, humans are resistant to change. But if you tell them the reasons why, I think most people are willing to make that choice because, oh, that makes sense as to why, even though I have decades worth of exercise training, why I shouldn't just trust myself.
So maybe go and see someone for a one-off and try to get a plan. It's not something you can't ask ChatGPT to generate that.
Unfortunately, that would be extremely dangerous.
Okay, all right. So now when people have completed cardio rehab, how soon after open heart surgery can people expect to begin to return to somewhat normal activity or the new norm?
Well, it doesn't even have to be necessarily at the conclusion of cardiac rehab. Possibly it happens while in rehab of returning to their new normal, and that there isn't necessarily a perfect science to an absolute target date for these things, but it plays into this idea of the exercise training not just being about exercise training in the literal way, but it is also about, as you're going through it, refamiliarizing yourself of what's a typical response, what's above and beyond the abnormal response, so that you can start to trust yourself again with making those judgment calls as to, is this appropriate, is this not appropriate? Because it also isn't just about the actual active exercise in a literal gym, because that's only a small fraction of your time. And it's also about, like you said before, you have individuals with very physical, demanding, active jobs before all this. And there's some elements that they probably can't do again, but there's probably some elements that they still can do when done a little bit differently, because they know why they're doing it because of their condition. And so 95% of your life is not exercise. And so you still want to make sure that you're making good choices with physical exertion, physical stress that you encounter throughout your day, in your yard, in your barn, in your garage, that can engender the same type of blood flow stress that you might do in an actual exercise session.
All right, speaking of farm work, let's talk about weights and lifting weights. So far, we've been talking about aerobic activity. So we love our aortic athlete weightlifters. They come to us and they join our group, and here's their question. I power lift 400 pounds. When can I still do that? I always say, well, don't quit, adapt. What's in aortic disease, the issue is spiking blood pressure. So what happens in that valsalva maneuver?
Yeah, that's a good question. So, the valsalva is typically 4 phases, and it's the first 2 phases that are going to be extremely dangerous for that blood pressure. And that initially, when you're essentially closing your glottis and you're trying to, blow against your closed glottis, you're purposely generating pressure in your chest to create a hydraulic pump, making your body like a hydraulic pump. And as you're pressing against that closed glottis, you're forcing blood from the pulmonary circulation into the left atrium, and then the left atrium into your left ventricle, and pressure follows blood flow. So the cardiac output, as that's increasing, pressure is increasing. And at some point, though, the pressure increases so much that you begin to prevent blood flow returning into the heart to generate another cardiac cycle, cardiac output. That makes your body then trigger a reflex response of, we need to constrict to increased systemic vascular resistance and blood pressure. So you actually then spike your systemic blood pressure as that's occurring. So it's during both those phases where you're generating first initially high central pressures and then followed by extremely high systemic vascular resistance and peripheral pressures that are causing all that pressure to essentially move against that wall of the aorta, and that creates what you call transmural pressure that wants to push things out and expand things. And it's that repetition of doing that over and over again where you continue to increase that risk, because every time it's a stimulus and your tissue is adaptable to repetitive stress.
So no grunting.
No, absolutely not. No, absolutely not. And there really isn't, I'd say, a compromise to the valsalva. There's not like a safe way to do the valsalva. The valsalva is what it is. And again, it's thinking about when you lift something heavy, why are you engaging the valsalva? What is that pausing inside your body that makes you want to do that, and that results in being able to lift the load, push the load, pull the load? And that, just like a hydraulic machine, that's what you're trying to make your body into.
All right, so we're on a continuum, let's say, and here's the valsalva over here, something we clearly don't want to do. Now, we have aortic athletes who have heard from their cardiologists that for the rest of their life, they can never lift over 10 pounds.
Yeah, well, I think, you know, at the opposite end of the spectrum, I think that's extreme, is that I don't think that that's the case. 10 pounds is like a gallon of milk.
Yeah.
Okay, and so, yes, absolutely. I think that in most cases, you can lift more than a gallon of milk. Now, is there an absolute weight number to not exceed? No, there isn't, because again, this comes down to the individual. Of every individual, let's say, for example, 50 pounds is going to be much different blood flow stress, physiological stress, just based on the natural build of the individual and their history. And so we can't just say one sheer raw absolute number. But again, the important information to remember is when you're lifting, it's to be able to lift it without having to engage something like the valsalva as a critical guide. Is to, if you're going to lift it and you feel yourself starting to bear down, you already know right there that's too much.
And so along the continuum, and including the continuum at cardio rehab, are you doing light weights, high reps, not to exhaustion? What are you doing for people in that cardio rehab process? Are you introducing any weights at all?
Yeah, absolutely. And typically that's going to come in, say, the last third or back half to last third. And yeah, in general, it is going to emphasize more repetition, concentration on form, but also to not push your body to that point of exhaustion, because you, for both aerobic and strength and weightlifting exercise, you generally do want to avoid pure exhaustion, because the cardiovascular system, when tired and stressed, starts to be deregulated. And that's when you start to see labile blood pressures, heart rate spikes, cardiovascular drift. And that's when, again, you're unintentionally causing more hemodynamic or blood flow stress within the system, despite possibly not necessarily changing the workload itself.
I heard Dr. Roselli from here at the Cleveland Clinic on a YouTube interview recently say that he had someone come in and say that their cardiologist said, don't lift more than 8 pounds. Dr. Roselli said, if you can't lift more than 8 pounds, I'm operating on you today. And his kind of not a rule of thumb, but he thinks about half of body weight, because if I step out of my chair, I'm lifting half my body weight, or so somewhere around there when I get out of a chair. So,
well, again, there can't be a sort of a universal rule like that, because Because again, you have to remember that even though you're a lifelong exerciser and love exercise, and probably most of our audience love exercise, is that there are many individuals who have never exercised in their life.
Yeah.
And it's a completely foreign concept. And so half your body weight for someone like that could actually be a great deal of stress for that individual to experience.
Is it the same thing with, let's call it isometric exercises, let's say wall sits? I was in a post-aortic dissection exercise study, and I still do it. Leg lifts for 2 minutes, wall sits. And they took our blood pressure during the exercise when they did the intake and stuff to make sure it wasn't over. I think they said 160 systolic or something. Mine was a lot lower. But how do you feel about isometric stuff? So we always get the question, can I do a plank? Can I do yoga?
Yeah. Well, so there's differences in the isometric exercise themselves. So doing a knee extension and holding it typically probably won't be a problem for you. Okay. But the concern would be when you're trying to engage basically all the muscle of your body like you would be doing in a plank. Okay, because there's quite a bit of evidence, data to support the fact that isometric exercise in that manner is going to generate the most systolic blood pressure versus an isotonic type of contraction. And so when you're doing that plank, you're basically engaging all the muscle of your body and generating a great deal of pressure that enables you to hold your body position in the position itself.
All right, so for our yoga practitioners out there, how about vinyasa flow? So they're not holding the position, but they're sort of moving through, you might go from, I don't know, downward facing dog to plank or something like that. And then, but out, and you're not really, maintaining it till your arms are shaking for 2 minutes. Any thoughts? Well, maybe it's person by person. You just have to.
Well, some of it's going to be person by person in terms of where you are in your aortic condition, of course, right? But that, let's say, even something like a vinyasa, you want to think about some of those maneuvers as to the degree of that whole body engagement in the movement itself. Also, want to be thinking about the torsional forces, the rotation that you experience with your body, the upper body twist. Okay. And so when you twist, and if you twist rapidly, that's also causing a twist inside your body too, and including your aorta. And so if you have aortic tissue that's compromised and you're putting torsion on it, then that certainly can be a risk factor for that weak intimal line.
So that's a question mark.
It is a question mark, and you exacerbate that if it's a hot environment as well.
Huh.
Okay, and certainly things where you're going to be doing, rapid down to up maneuvers, okay, and vice versa, where you're causing essentially your body to work against the G-forces of gravity. Okay, because blood is a fluid, and the faster you move it, the more inertia that you have behind it.
Joshua, I'll bet we have some questions.
We certainly do, sir. First, let's start off by saying hello to some of our regulars. Natalie, Katie, Tom, Velda. You're being joined by Brad Way, he jumped in here, and Greer Schneider, he jumped in here. LM Sanchez. Right away, we have some questions. Brad started with, it seems like sports cardiology isn't as widely recognized as it should be. Why do you think that is?
Well, I think in many ways, it's just a newer specialty where it hasn't really caught a lot of traction for whatever reason. I don't have a fundamentally good answer as to why it hasn't caught traction like that. But that, yes, I think that sometimes the medical community may just take it for granted that if you're a cardiologist and a physician, that you just already know this without having to have a sports cardiology specialty itself.
I think a lot of us, we may see cardiologists who have their own personal biases. They may see most of their patients who are sedentary, and we appear as a freak. You want to do what? So yeah, so it's an interesting subspecialty. Maybe it'll grow. But I think the opportunity is there for aortic athletes to push asking for the exercise stress test. Kind of educating our cardiologists a little, who may not have think that that's really a good thing, or just wouldn't occur to them.
Absolutely. I would always encourage question asking, and that in most cases, if a cardiologist physician doesn't know, then they know to say they don't know and to refer you to a specialist or someone who they think does have a better understanding of the question itself.
Joshua, others?
Okay. Oh, we have a couple more for sure. A follow-up question is, how do you determine when someone should seek out a sports cardiologist versus following a more traditional cardiac recovery path?
Well, I don't think there's a right or wrong way for this either, in that a cardiologist doesn't necessarily have to be a sports cardiologist to know the ins and outs of exercising following an aortic procedure. Is that because sports cardiology is relatively new, is that it's possible that your cardiologist still knows the content, the topic very well. They just trained way before the specialty was even recognized. And so I think that's certainly something that you should give your cardiologists, the benefit of the doubt, or at least ask questions about their familiarity with that before feeling like it has to be an either or.
Okay, thank you for that, Doctor. With the advancements in wearable technology like Garmin and Apple Watch, are you aware of any emerging technologies that could provide better real-time metrics for patient monitoring in the future?
As of right now, no, I don't know of any, wearable technologies that, let's say, the FDA would have reviewed and approved as an at-home medical device for the specific purposes of exercise training. And that I could be wrong, and that may be in the process, but I'm not aware of that level of granularity with the technology at this point. But with that, I would also add is that wearable technology can provide useful information when it's used appropriately in the right context, but it can also provide a great deal of concern and angst when used when it probably shouldn't be reviewed or interpreted.
What's an example of that, of the latter?
Yeah, so a good example is if, let's say, not picking on, Apple Watch or Google Pixel, but let's just say you have one of those things and you have the heart rate function screen on, and you're just going around your house doing activities of daily living, which by nature are very dynamic, very quick, very short. And by no means should they ever be interpreted as a steady state condition. And that your device is acquiring heart rate data through all of those tasks. But that heart rate data is very reflective of your activities of daily living, dynamic, quick, and short in nature. And so when you go back and maybe look at the data in a spreadsheet or even in real time, you see these very quick or out of context numbers that, when viewed in isolation, may make you think a certain thing, when in fact it's just your body's natural response to that activity.
So if you walk up the stairs, your heart rate might spike for a second.
Sure, yeah. Or if you bend down and you're unloading the dishwasher and grab a plate and you go reach up high to put it up on the top shelf, your heart rate's going to spike. And so you don't want to interpret that type of heart rate spike as the equivalent of the heart rate during an exercise bout. That is inappropriate.
Okay, thank you for that, doctor. Moving into a different topic here, can you talk a little bit about the recovery of chest muscles after open heart surgery? What is the expectation around range of motion?
Limited to begin with, absolutely, that would be completely normal, and that it is important, even before leaving the hospital, that you have education discussion about a very basic range of motion flexibility regimen that you can do every single day. And in that way, over time, probably throughout the cardiac rehab process, you do eventually start to regain your full range of motion again, upper body wise, but also of the lower body as well. As that with the lying in bed, you probably also tend to start to experience some surprising low back soreness, stiffness, pain that maybe you never had before. And a lot of that is just due to the nature of the muscle deconditioning that you experience from being essentially unloaded for that period of time, and as short as, unfortunately, 3 to 4 days.
I kiddingly asked Dr. Vargo before he operated on me here at the Cleveland Clinic 3 years ago to gently open the chest because my back hurt. And the only thing that's helped over time is just high rep, low weight, like 12-pound arm curls, bicep curls. Over time, I don't know, that's just kind of helped reduce it. It hasn't eliminated it, but it's reduced it somewhat.
Yeah, because, well, you also unfortunately experience the imbalance of having the chest opened, them cutting through the pectoral muscle, the clavicle, and then them resuturing it together. And as that's healing, though, everything's being pulled forward in forward flexion. So that's automatically going to put strain on your back muscles because they're being pulled forward as well as you're healing. So that flexibility range of motion is more than just stretching the front side of your body, but it's also to try to reestablish some of that balance in the back muscles as well.
Yeah. There's the number one complaint of aortic athletes is beta blocker. Number 2 is chronic back pain. All right, what else, Joshua?
All right, let's see here. A quick check back to the technology. Greer says, as a follow up to Brad's question on new technologies, any thoughts on continuous lactate monitors?
I don't generally see value in that. I don't, well, for one, I don't know of any reliable continuous lactate monitors for the purposes of exercise itself. But that I don't also think you necessarily need to have a pure lactate value to know that you are at the lactate threshold or above. And that when you have objective heart rate data, let's just say you've done an exercise stress test, someone's calculated out the various percentages of your heart rate reserve, and they know what they're talking about in terms of deciphering at what percentages you're likely below the lactate threshold and above. I think at that level, you can generally make that choice of you are or aren't above or below that threshold point, and that if you are, then you do have to be honest with yourself in terms of you can't continue just to grade things as mild. That's again part of the mental game here of being okay with subjectively selling something that isn't impossible feeling.
Okay, thank you for that, doctor. We have a kind of a 2-part question here. Natalie asks, if your medication changes, should you redo the treadmill test to redefine your heart rate target? I recently had to stop beta blockers, and it dramatically changed my ability in the cardio rehab program. Heart rate is always elevated compared to before when taking beta blockers.
Yeah, absolutely. And that's a excellent question. And yes, we would have our patients redo that stress if something as obvious as that weightlifting therapy change. So I think that it only serves to help you in terms of, again, being most representative of you in the present and going forward, not the past you that was optimally medicated with a drug that is intentionally affecting something that you're trying to use to help with exercise. And so I actually don't see how that you can really comfortably exercise now, not being on the medication and maybe being told training guidelines based on that medication, because you're almost always going to be out of range.
Okay. Joshua, maybe one more.
Well, we have one comment here, and that'll clean us up here. Brad says, by the way, I'm a former patient of Dr. Singh and very happy with the Cleveland Clinic Sports Cardiology Department. Keep up the good work.
How about that?
Thank you.
And then, all right, one last question. Some of us have exercise hypotension. So when we run, our blood pressure goes low. What can we do if we're out jogging? What can we do to mitigate too low blood pressure?
Good question. One is hydration. Really being vigilant about hydration, not just in the midst of exercise, but 24/7, all the time. Being vigilant about that. Don't wait for your body to tell you you're thirsty. It's already almost too late at that point. Be cognizant of the temperature, that if you're in a hotter environment, then again, as part of the thermal regulation system, your body wants to dilate and dissipate central heat in your core temperature to move blood flow to the periphery for skin blood flow for thermal cooling. Another thing to consider would be compression stockings that can help act as an exoskeleton to sort of pull things tight and lessen the ability of that vasculature to expand and to accommodate fluid. And so there isn't, I think, going to ever be a single thing that's going to mitigate that. But I think, again, the theme of exercise training being consistent, when you do all of the above consistently, then I think you have the best chance to being preventive about the exercise hypotension, as opposed to just playing it by chance and take into consideration your baseline when you're exercising.
All right. Well, listen, Dr. Van Iterson, this has been a feast of cardio rehab and exercise. Here, I do want to give you, let's see here. We have swag at Aortic Athletes. Now that we're coming live, this is our Aortic Athletes hat.
Well, I'm grateful. Thank you very much.
Thank you.
I will wear it with pride when I'm doing my own biking.
All right.
It's awesome.
Okay. Thank you so much for joining us today. And thank you all for listening. Remember to click like, and AI will send this video far afield. So please do that and join us on Facebook at Aortic Athletes, and also join our friends at Aortic Hope. Thanks so much, everyone.
Thank you.
And we'll see you.
Thank you, everyone, for your time.